All right, Dr. Catherine.
It's 12 noon, Thursday, March 20th. We'll call to order the Protocols, Medications, and Devices Standing Committee meeting. Roll call, please.
Amber Wright. Present. Erin O'Connor.
She let me know she'd be at a conference right now.
Oh,
Would be your everybody for emergency comments?
Yeah, my wife.
Mr. Key, present.
Brian Schmitz. Present. Cody Jordan. Welcome. Rocco Castramarin.
Present.
Dark Gamer.
Present.
Heather Miller.
Present.
Jason Johnson.
Here.
Josh Gaither.
Here.
Matt Shaw.
Present.
Paul Dabrowski. Philip Hannon. Shari Brand. Oh, 10, we have quorum.
Okay. Thank you so much. Just as a housekeeping matter, if anyone misses 2 consecutive meetings in a row, the Bureau will reach out and check in to verify your continued participation on the committee. At this time, please review attachment 3A for the attendance report that is available online. And then following that, we're welcoming a new member, Cody Jordan, paramedic. Welcome, sir.
Thank you. Happy to be here.
At this time, we don't have any vacancies on this committee. And we also have the 2025 meeting schedule available online for your future planning. Bureau report, please.
All right, I will do my best to cover the portions that Nicole Wood is not able to join right now. She has another statewide meeting she's participating in. First one, do a couple of congratulations. The first one is to Likia Castro, who has applied for and been named as the new certification manager. She took over for Maria, who retired from the state after 30 plus years. So congratulations to Likia. Also want to congratulate Brett Caswell, who is now officially the enforcement program manager. He has been interim in that role for several months and wanted to say congratulations to him as well. We would like to welcome back Lance Stubbins as the new enforcement investigator. He was previously with the Bureau. And then also make official Mitch Adair, who is now going to be full-time as an enforcement investigator as well. And then welcoming Stephanie Portwright as a CO1 administrator. We do have 2 open positions, most notably the Bureau Chief position. This is still open in the recruiting process. If you know anyone who is interested and would like to apply, please let them know. There is a link to this in the slide deck. The slide deck will go out after the meeting as well. Also, the trauma compliance manager. This is also open as a position too. I will cover quickly the key and trauma award, the MCT of the Year award. Just a reminder that these are selected by the regional council. Anyone was able to submit a nominee. Each regional council will determine who will get the award, and these will be given out at the May meeting of the EMS Council. For the trauma award, these are open again to anyone to submit nominations. The nominating committee is a group of individuals who volunteered to do this. They are all outside of the Bureau, so we are not participating in the selection. There will be a total of 8 individuals recognized for those. In regard to the timeline, winners will be chosen in April. We will have the awards at our May 8th meeting. So just a reminder for everyone's calendar, if you're part of the committee, you do get the calendar invite. If not, this is not our normal third Thursday meeting cadence, just because of some other conflict. But we will have May 8th at the State Trauma Advisory Board, the 9 a.m. meeting. We will give out the trauma award. And it's a 10:30 EMS Council meeting. It's when we will award the MCT of the Year awards. Some portal changes is quickly covering this. The main part is highlighted in yellow, just with the transition of the database with image trend. The renewal certifications that come out will be my .com email address. Just a big reminder, as sometimes those do go to spam, all EMTs and paramedics get a 90, 60, 30-day reminder for renewal notification. So just make sure people check their spam folders if they have not yet received that. Other Bureau news and updates. If you're looking for the most up-to-date version of our Bureau statute rulebook, this is linked to the slide deck and it's also on the Bureau's website. Thank you to David Harden for updating that. That includes a lot of the changes that were approved by this committee, including scope of practice as well. We also have links to two databases, which are the HEAT database and opioid. These are both linked on our website. Thank you, Kim, for also linking in the Arizona HEAT events kickoff. That time frame is in place as well. So those are two dashboards that are available. When I looked at the weather forecast for Maricopa County for next week, we're looking at the high 90s. Hopefully that does not forecast at summer temperatures, but the state is seeing a lot of attention on heat related to illness and injuries and prevention moving forward. And then we did send out communication earlier this week by our Gov Delivery system regarding poison control and Arizona poison control with information and outreach resources. Is there a desired timeline for the naming of the new bureau chiefs? There is not a desired time frame outside of, I'm sure Nicole would say, ASAP. It's just a matter of getting applicants and the hiring process. So the position is getting reposted if it has not been reposted, I think this week. In regards to scope of practice, I know this committee was very actively involved, so likely very few questions coming from this group, but I do get questions probably on a weekly basis, as does Marissa, regarding scope of practice updates. So we are going to continue to advertise this to all of our committee meetings over the course of 2025. And again, a big thank you to this group who really were instrumental in working the updates to scope of practice with the addition of the EMR level, as well as the critical care endorsement. That was a really big list from this group. So thank you to everyone who participated in that process. Drug tables, again, this is another item that we get quite a few questions on. These are also, both of these scope of practice and drug tables are on the Maine Bureau's website. If you go to the bullet point at the top of the page, you will see the hyperlink to the most up-to-date versions of this. I think the thing that we get the most questions currently on is in relation to hospital-based paramedics, which is the table 3B. As a reminder, this group approved really expanding that scope of practice for critical care endorsed paramedics, really adding more oral agents to the hospital-based paramedic drug table. Naloxone leave behind, a huge thank you to all the medical directors and EMS agencies that are participating in this program. It is really impressive to see we have over 53 agencies across the state of Arizona who are now actively participating in naloxone leave behind. We have almost 4,000 EMTs and paramedics in the state that are trained in this. To give you a context, this is about 1/4 of every certified EMS provider in the state is trained in naloxone leave behind. So really incredible numbers. But as we see that increased number of agencies, our number of kits getting being handed out to cities, community has gone up as well. We are up to 857 kits that have been scanned. One thing we do want to point out that we're trying to advertise as well, if you can see in the picture on the slide deck, there's this small QR code that is on the actual kit that's just given out to communities. We do recognize that some EMS providers have given a kit out and forgotten to scan the QR code at that time. It is the same QR code on all of these. It takes you to a quick form where the EMT or paramedic essentially selects the agency and then the zip code of where they're giving the kit out. So even if they give the kit out, they can still scan another kit to record that information. I'll hand it over to Adam.
Sure. Hi, everybody. This is Adam. What you're looking at is from the desk of our EMSD, Brianna Smith. These are pediatric emergency care coordinator role guides. There's two of them. One is for PECs in the hospital setting, and one is for PECs in the pre-hospital setting. A PEC is really the crux of our program. We're reliant on that volunteer position at either a hospital or an EMS agency to act as a pediatric champion, as a volunteer with a passion for pediatrics, and we'll utilize that contact with you as a conduit to get information and give information, training and resources and things like that. So these are those role guides that help understand, that help define what it is PECs do, what they are, who they can be, and things like this. If you have questions about that, scan the QR code and follow up with Brianna Smith, and I'll pause for questions if there's any. And I can also do the next slide if there aren't any questions. A quick share update. we are exploring a new method of case matching to make the process more automated with the hopes of eventually creating a dashboard. Second to that, we're exploring our options for alignment with national standards. If there are any questions about SHARE program, please contact me or my data counterpart, Josie Johnson. Thank you, Dr. Fredley.
And just one more item on the SHARE program. Wanted to remind everyone that is a premier EMS agency program or have that recognition. EMS Council in May of last year did adopt the addition of the cardiac arrest data elements as part of the SHARE program to be a premier EMS agency. That data collection started in January. We have gotten questions from agencies wanting to know, where are we as an agency? Are we going to lose our PEEP status? The short answer is you will not lose your PEEP status. Really, our goal is to automate the data as much as possible. In the next month, we should have some reports that will go out to your agency so you can see how you're doing with the cardiac arrest data element and really what we can do to help improve and support the data completion for this function. One key piece I want to mention is that the reports will be going to the point of contact for your PEEP designation, which is connected with David Harden. So if your agency has had a change in that individual or you'd like someone else to get this report, please reach out to David Harden and he will make sure that he updates the list for that. A quick note on our EMS and trauma data dashboard. We have Lowe's link here. This is a link to our Bureau dashboards regarding both EMS and trauma. Huge thank you to Bothell, Josie, and Carissa for all of their work on these dashboards. It's amazing the amount of information that is available. We would really like to advertise this. The link is on the slide deck that will go out as well. One thing we wanted to point out is that there are jurisdictions in the state that have used this data to actually apply for grants at the federal level and having awarded funding for that. So if you're interested in anything, if you're a hospital, you're looking for data regarding traumas, all of that information is available on the Bureau's website. A trauma registry system update. I will cover this briefly on courses we have. The short story is the previous vendor for our trauma registry sunsetted their program, and there was an RFP process that was awarded, and CSO is the new registry system. And if you have any questions trauma registry related, please reach out to Chris on that. Grant opportunities. I really wanted to highlight this. Thank you for David Harden, who really tried to get the information out regarding this. If you see on the slide deck, there's approximately $2 billion, so with a B, not an M, of funding that has been appropriated at the federal level to support what they term the Safe Streets for All program. There's a number of awards that are out there. I'm going to call on Dr. Gaither once again and put him on the spot to kind of briefly cover what he applied for as part of this funding to get awarded.
Sure. Thanks, Dr. Bradley. Just briefly, because I think everybody's heard my feel, almost everybody at this point in time. This is a federal grant mechanism that they are really pushing for EMS agencies to consider. We applied for and were awarded this grant through the University of Arizona in the calendar year 25. There are 3 types of grants you can apply for. The first is a planning grant. Those are designed for public health department, Department of Transportation. The second 2 are demonstration and implementation grants. Those grants are designed for people like us to implement projects that improve the safety of your road. That includes responding to highway traffic accidents, which is what we do all day, every day. Our program implements prehospital physician field response. It will provide a physician who's available 365 days a year to respond to high acuity calls. And through that program, we make available advanced care, things like blood products, advanced ventilators, advanced surgical procedures, all that type of stuff. So think about that as maybe a little food for thought and how your system might go after similar funding through this mechanism. I'm happy to talk about the program or other options offline.
Thank you. And just to clarify, this is something that it has to be a jurisdiction that applies to the Bureau of EMS, and ADHS is not able to apply for any of this funding. It is jurisdiction based. So we do try to get the messaging out there, as we know that there are many agencies looking at for funding to support various programs. I think that is the last of the slide. I will briefly cover the update on the strategic plan that Nicole had also covered in a previous meeting. The strategic plan, a big thank you to everyone who participated in that process. That went through the 4 regional councils, including multiple different stakeholder organizations. And then we did have our 4-hour strategic planning summit that many of you participated in. So we do have our strategic plan in place that has gone from the director's office to the governor's office. We are waiting for the final approval process so we can implement some of that strategic planning. One of the things that people have questioned is, are we behind a little bit? Reminder, the strategic plan is actually a 5-year plan. So 2025 through 2030. So we are still in the very early stages of this. And I think we're well positioned in the next few months to start hopefully forming some work groups to address portions of that strategic plan. So we just wanted to make sure that we brought that up to the group today. This is still on our radar and we still plan on implementing that. It's in the Bureau report, Dr. Councilor.
Thank you, Dr. Bradley. So moving on to our discussion and action items. The first item is to approve the draft minutes from November 21st, 2024, available on attachment 5A, excuse me. May I have a motion?
Motion to discuss. This is Amber.
Second, Brian.
Thank you. It's been moved and seconded to approve the minutes. Are there any amendments or any discussion needed? If not, let's go ahead and call for a vote. All those in favor of approving this motion, say aye.
Aye.
Any opposed, say nay.
Aye.
Any abstentions? Okay, that motion carries. Thank you. Next is to approve the draft update for Table 1 titled EMCT Drug Box in order to add oxygen to the EMR scope. May I have a motion?
So moved. Second.
It's been moved and seconded to approve the Table 1 drug box draft update. Any discussion or amendments needed?
Dr. Gessmer, just for clarification, this is for the drug table, not for scope, just to make sure, because we don't have scope practice at the moment. So just to make sure the verbiage is correct in that to amend the drug table.
Thank you.
I'll only offer my support. Thank you.
Sounds
Right
good.
thing to do.
Yep.
Yeah, I'm assuming it's what's in there.
Okay, so hearing no further discussion or amendment concerns, let's call for a vote. All those in favor of the motion, please say aye.
Aye.
Any opposed, say nay.
Nay.
Any abstentions? Okay, thank you. The motion carries. Item C is to review the minimum quantities of drug options on Table 1. This will be attachment 5C. May I have a motion?
So moved.
Any second?
Yeah.
All right, thank you. It's been moved and seconded to review the minimum quantities of optional drugs on Table 1. Again, that's attachment 5C. Any discussion or amendments?
I can give a little bit of background. This was brought forward for me to kind of have the committee consider when we have expanded the drug table with the addition of quite a few medications as part of the critical care endorsement. Something that individual identifies with that some of our optional agents have a minimum supply. Other optional agents do not have a minimum supply. And so the question was, do we want to consider essentially not having a minimum if we have optional agents? So I know there are quite a few, Shelley, maybe scrolling through to give the committee time to look at that. But that is the background of where the request came from, was in regards to specifically kind of the inconsistency of minimum.
Can I add just a little bit more context to that as well? So although they are optional agents, it's always been historic that they are to have enough to treat one patient. So when the regional coordinators go out and inspect drug boxes, if it's an optional agent, there's like minimum supply, that agency is required to carry the minimum supply that is in here. So that's what they go out to check.
And so, Dr. Bradley, the question would be to consider removing the minimum quantity on all drugs that are considered optional. Is that what I'm hearing?
That was the question that was asked. I think that's for this committee to decide. Do they want to do that for all or just review and do some of them?
Or alternatively, you could add in the minimums on the ones that are missing.
The one that was identified with an example with accommodate, it's an optional agent. The optional amount is 3 milligrams, really probably twice what anyone is actually administering. And so for many agencies, the question is, are they carrying more medication than they would actually need and then wasting that drug supply? So again, we try to bring, when questions like this come up, bring them to the committee to discuss. As obviously, if it were approved, that PMD would still go to MDT for further discussion, but
And if it's optional, then that is the minimum supply. They can always carry more if they, as the medical director, means they can carry more.
Some of them are, that might be challenging. I mean, like for antibiotics.
I was gonna
that's a
say,
whole lot of
I was gonna
options.
say the critical
So-
care one pose a little bit of an
Right.
issue.
Yeah.
Because the
blood.
ones added for critical care, I think are difficult to have a minimum necessarily. ESMO, you know, how do you, some of these drips and things like that, I don't know how you necessarily,
Right.
quantify a minimum.
Isn't that what we pay? The Crotabab or whatever it's called now. I mean,
Yeah.
it's gonna be different based on.
And if you look at atropine at the second page, to be the pre-filled syringe, a total of 1 milligram, but then we also have the optional 8 milligram multi-dose vial. You know, it's an optional with the amount. So,
Right, but most of the multi-dose vials are for things like overdoses, or like toxicologic things, and they're not for normal EMS calls, they're for treatment of other things. So I think it does make it challenging to, for some, or a large number of you to feel like the, I don't know, really good
Yeah.
minimum number.
Well, and even something like that, everybody is using hemostatic agents.
Right.
Right.
How do you put a number of that down?
Right.
I don't see any of these that would be problematic to remove the minimum supply.
Agreed.
I mean, the one that pops out to me as maybe problematic is the cyanide antidote, hydroxycobalamin. But that comes in a kit that's 5 grams. It does have a 2.5 gram vial option, but that option's actually gone. So none of these jump out to me as, man, we're gonna really cause risk if we remove them.
I think the only other thing that we had chatted about a little bit previously were the things like the diazepam, lorazepam, midazolam one, where it has a minimum number, but some of them are optional, right?
they're not optional.
No,
I think-
it's or.
Or, so I think that
But
would,
the diazepam optional below.
Yeah, it's 25 milligram.
Rectal delivery.
That's rectal.
Yeah, you're right.
So you just have to carry one or the other. So those are not optional.
Yeah, you're right.
You have to
They're not
carry one, and it seems like it's reasonable that you would
Yeah.
want to.
Yeah.
I think the question that has come to me, I know has been, well, if we carry 10 milligrams of midazolam and we want to have like a little bit of lorazepam as a backup, do we need the full 8 milligrams? With the current verbiage, the answer would be yes, because it is listed as a minimum. So I think that is the question, but that is, I think, one of our few exceptions of where there's an or agent. The other one is morphine or fentanyl. That's the other option where there's not, it's not an option, but it is 2 medications.
So Dr. Bradley, is the goal to have an up or down vote on this decision today?
I mean, it's on the table for the group to vote on, so certainly if the group wanted more time to review this and come back, it could be tabled, or if the group wanted to go through this for the adoption age now, it's really up to the group to decide.
It's on here to review this. It's not on here to take any other action at this point in time on it.
I guess there's our answer. We are reviewing and deciding if we
Yep.
want to make an action item for the next meeting.
Yes, that's kind of why I asked the question, to make sure I understood.
So we just need to decide it's even worth changing or taking it off.
I think I would support an action item at the next meeting to review all minimum requirements, remove all minimum requirements for those drugs listed as optional.
And potentially discuss the clarification to the benzodiazepine box.
I don't know. I would have to get with our rule writer on that. I don't know that that's gonna be tricky just because
We don't think she'll let you do it.
I don't know that we can do an
Okay.
answer to
Okay.
that.
Well, then
About
leave
that,
it.
what I can find out is I would say, even if we just stress the minimum requirement for optional, I think that would clean that up quite a bit.
Yeah, agreed.
Yeah, I was gonna, rather than making a recommendation to remove them or not remove them at this point, is to have it to be, to review and amend optional agents on the drug box list for minimum quantities. And then whichever way it goes with everybody, then you could remove them, you could add to the others, you can remove them if you make it more generic than that, I think.
Any additional discussion?
What is the downside to removing if right now the reason that the optional medications have that minimum is for when the boxes get inspected? What is the downside to having no minimum? Or what are the implications
I
of
don't
that?
think it's just that, like, you know, if that's just how we're expecting
Yeah.
that. I think the downside in my view of things would be that there's a possibility that agencies would be carrying less than a dose for one patient, you know?
Yeah.
And then at that point, when we are expecting, and there's no minimum, they have it or they don't. And so right now they're held to having, if they're carrying it for what this, you know, committee has decided that is the minimum for them.
I think one thing is, these are right now, these are optional drugs. We're not talking about the drugs that this committee and medical direction commission and the director have decided are important enough to be required. And in order to do that, you assure that you have whatever minimum quantity is appropriate. But it seems like these have to be approved by a medical director, and for a medical director to go, we're going to carry 2 milligrams of something versus it requires 10 milligrams is not in the best interest of being a medical director.
Yeah.
That potentially sets them up for issues. So I don't know for the optional items that it just doesn't seem reasonable that they would approve it and have some substandard dosing for each patient.
And that's kind of what I was thinking too, because like the medications I would say are your critical medications, it's not optional. So it's already there. You have to have those.
Right.
Both of these options two fall under the critical care stuff anyway.
Right.
So if you're gonna have a protocol that you're using those, presumably you also are gearing up to follow that protocol.
Right.
Yeah.
I have a question for the medical directors in the room. I guess in your experience, have you been asked or do you have a role in actually deciding what the minimum quantities are being carried in your units? Is that something that comes up in your routine operations discussions?
I do. I review mine yearly with the agency.
Yeah. And I literally just had a meeting yesterday going over those.
Yeah.
Sorry,
We have a hand raised.
Go ahead,
hi.
Dr. Zeidler.
Hey, it's Zeidler. I was just going to say, yes, that I have that discussion frequently with my agencies. And it depends on the agencies and how they restock. Do they restock back at their station? Do they restock back at the hospital? Where are they transporting to? So it's very multifactorial. But I would like the group to consider removing a minimum on optional medicines. Thank you.
Any other discussion? Okay, hearing none, then we will go ahead and I guess table that if it wants to be added to as a specific up or down vote action item for the next meeting. We will move on to item D, which is to discuss development of drug profiles for additions to table 1, which is going to be attachment 5D. That attachment is just the excerpts, the first 4 table of contents for the current drug profiles. May I have a motion?
So moved.
All right, it's been moved and seconded to discuss development of drug profile additions to table 1. Any discussion?
And you're missing me pointing at Shelley. All joking aside, Shelley did identify that we don't have as we've expanded the drug table, we do not have drug profiles for a number of medications. That being said, I think the majority of the medications we added were for the critical care endorsement, which, the agencies and their medical directors should have training on. So it just is whether this committee wants to take on the workload of developing drug tables for those missing medications would be really the question for this group.
Is it only the critical care ones that we're missing?
Is the housekeeping question.
Yeah, I mean, I would definitely be for, if we have like primary drug box that we're missing, I think we should definitely do those, but if it's just the critical care ones, I just wasn't sure. If it's just critical care ones that we're missing.
That's my thought too. It's like if it's one that's in the standard drug box,
Yeah.
and we don't have it, then we should, but I wouldn't necessarily have to do the ProFab.
Right.
I don't think I know that either.
Without 100% certainty, when I think of the newer medications that we've added to the just general drug box out there before the critical care edition, I think one of the newer ones was TSA. We do have a drug profile for TSA.
I'm just putting a oral meds before, then we've added those previously, but I don't think we're missing any others.
And that hospital based.
Yeah.
Expansion was really is on the hospital based list. On the primary table one for kind of EMT through general paramedics, we can do a cross check and maybe bring that back to speed, but I don't know that we've added any significant medications half THA that we don't have a drug profile for.
I think everything that has come here has had a profile by the time it went on the list that I can think of.
But I think it's a good point just at least have this group discuss, are we comfortable not having those profiles for those things that are now in that critical care endorsement section?
I am. I think that the amount of training generally requires to take those medications would be far beyond what we would create as a drug profile.
And they've already had to take their national certification test anyway over those medications.
Yeah, I just think that the training for those is so much more extensive than the general drug box.
So we will check that within the Bureau and see if there are any kind of standard table one medications outside the critical care endorsement that we don't have a drug profile for. And if there are any, we'll bring that back to the next meeting. That it sounds like that's what that's
reasonable. Thank you for your consideration.
I mean, I would just add though that the drug table also does serve the role of somewhat of an appendix in terms of directing you, for example, to different guidelines, treatment guidelines, and things like that that include the drug. And so, yeah, I get that it doesn't have a lot of high value in terms of education or reference or looking up doses or things like that. It does have a little bit of a roadmap function as well for cross-referencing other documents. In case that matters to anyone.
Yeah, I think we currently have protocols for any of the critical care meds. So I think if we had decided to develop protocols for critical care,
Then we would need to.
then I think that the drug profile might be appropriate.
Got it.
But yeah, good point, Franco.
Yeah.
There is one that I don't see on here unless I'm blind, which is the hydroxychloroquine. Oh, there it is. Never mind. I am blind. Disregard. Sorry.
Any other discussion? All right, hearing none, that concludes the action items for today's meeting. Next is a reminder to forward any agenda items to be considered for the next meeting to Shelley, whose email address is on today's agenda. Let's see. Next item is call to the public. All right, so next item, upcoming events. In April, we've got 3 events listed on the calendar. NAEMT's EMS Hill on the Day, EMS on the Hill Day in Washington, D.C. On April 17th, Phoenix Children's Child Maltreatment Symposium here in town. And at the end of the month in April, we have Trauma in the White Mountains Conference up in Snowflake. In July is the AIMS EMS Odyssey Conference. Please visit the Bureau's news and conferences page for additional entries and information. The next PMD meeting is on the schedule for July 10th, 2025 at noon. Can I get a motion to adjourn?
So moved.
Second.
Thank you. Thank you, everyone. Thank you, Shelley.
Thank you.